Today we will be addressing the subject of tuberculosis. Today is 24th of March 2021. It is celebrated as the World Tuberculosis Day. I wonder if we need to celebrate a day as a tuberculosis day or we need to create awareness. Either way, it's not so welcome. We should not be having a disease with us, amongst us, which has been known to us as a communicable infectious disease for decades and decades. To just put certain facts on the board, on the platform, I don't think I'm voicing facts which are new to you all. But let's just look at the burden of the disease. It's not about statistics, it's not about maths, it's not about numbers, but it's about the very fact that 1/4 of the world's tuberculosis cases are in India. We can always give an excuse that we are one amongst the most populated country, but that does not justify the presence of a disease for which we've been working so hard, and we have eminent people on our panel wanting to tide over this disease and keep it at bay. Yet, 36% of the deaths due to tuberculosis happen in India amongst the affected. The disease is curable. It's unfortunate we still have deaths, but that's probably because we have a lot of MDR, multi-drug resistant cases, when it comes to giving anti-tubercular therapy, ATT. So MDR is a battle that we need to fight. They say nearly 9% of the cases are MDR at least. So I think this world should be a world which should be free of tuberculosis. If we can fight a battle against smallpox, if we are raging a battle against pulse polio, and currently we are having a virtual guerrilla warfare against COVID, let's today address the issue of tuberculosis, commonly known as COGS. Today we have 3 distinguished guests on our panel. Foremost, we have here Dr. Gopalan Narendran. We have an eminent institute called NIRT, of which he is the deputy director, and this is a division of ICMR, which is stationed at Chennai. Dr. Narendran is a scientist, E-category medical, and he's a clinician cum pulmonologist. So we have somebody both with a scientific and a clinician bent of mind at an apical institution of our country. He, of course, has been awarded Nasi Scopus National Award in Medicine in 2014 for his work, and his key interest is, but of course, MDR, tuberculosis, and also HIV, which is associated with tuberculosis in quite many cases, or vice versa. He has been STREAM Stage 2 Principal Investigator, and he has been closely involved in setting certain guidelines which were related to central TB, NTB elimination program, etc. Welcome, Dr. Narendran, to this show.
Namaste, ma'am.
Namaskar, sir.
Thank you so much for the kind consideration and introduction. So, way back, world found TB, that is Robert Koch found it in 1882 on the same day, March 24th. And 100 years later, we had HIV being found. And both of them having a very good comradeship, trying to shake the world. Till such time, COVID started doing it in a very faster way.
True.
So the biggest problem which is being promulgated by TB is that despite centuries, it has been living with us for centuries, but still evading the immune system. Of course, my senior colleagues and professors, Dr. Krishna Prasad sir and Khilnani can talk much about it.
Yes, I will introduce them, Dr. Gopalan. Thank you for handing me over the bait. And we have with us Professor Dr. G.C. Khilnani. Dr. Khilnani is presently the chairman of the Institute of Pulmonary Critical Care and Sleep Medicine at PSRI, Hospital and Research Institute in New Delhi. He was formerly the professor and head of the same department in All India Institute of Medical Sciences at New Delhi. He has been a teacher to generations of students who have done DM under him. He has more than 250 research papers with interest areas in air pollution, non-invasive ventilation, ICU infections, and of course has the credit of forming quite many practice guidelines in asthma, COPD, pneumonia, non-invasive ventilation, and recently guidelines for antibiotic prescriptions in ICUs. He's a fellow of the American College of Chest Physicians, global governor of the same body. He has been the president of the National College of Chest Physicians, executive member of Indian Chest Society, and so on and so forth. Dr. Khilnani, I welcome you to the show.
Thank you.
Namaskar. Moving on, we have Professor Krishna Prasad here with us as well. It is such a pleasure, sir, to have you. You are a molecular immunologist, and he too has worked at AIIMS and was formerly a professor in the Department of Biotechnology and in charge of the immunology lab. Currently, of course, he's working and he's the adjunct professor in the Department of Microbiology in JSS Medical College at Mysore. He is a PhD from AIIMS, postdoctoral fellow from US, and his key interest, from what I have gathered, is human immune response. But of course, also about zoonotic tuberculosis, bioinformatics, and the molecular biology techniques and diagnostics hereof. Welcome, Professor Krishna Prasad, to the panel.
Thank you.
So as we move on, I have certain questions to ask, which I think should start on from the people who are just joined the show to the people who would be interested in your research work to the way forward. And going about it, I would like to first ask a very simple question. That is, multi-drug resistance has been a challenge. Professor Khilnani, may I ask you about your insights regarding that?
So, multi-drug resistant tuberculosis, to scare you a bit, almost 30 years back or 35 years back when I joined pulmonary medicine, there were editorials talking about MDR, a death sentence like this, And what is multi-drug resistant tuberculosis? By definition is that when the Mycobacterium tuberculosis is resistant to rifampicin and INH with or without resistance to other drugs. Why it is important? Because these are the most potent drugs that we have for tuberculosis, and whenever the person has MDR tuberculosis, the treatment becomes longer. That is, usually it is 18 months, but now shorter regimens are coming. Usually it requires injections for 6 months. These drugs are very expensive and very difficult to tolerate. But the worst part is that despite the best of efforts, the success of treating MDR is about 50%, and it has been like this for a very long time. Now, why this MDR? When Robert Koch detected Mycobacterium tuberculosis and the drugs had not come, there was no MDR. It is a man-made problem, because what happens that when the streptomycin came in the early 1940s, people thought that it was a magic drug. But soon it was realized that there was resistance to streptomycin. Then came PAS and INH. And as the drugs started coming, and then we started instituting them, the resistance started developing. So when I was reading medicine, we used to treat tuberculosis with 2 drugs, then it came 3 drugs, then it became 4 drugs. This is because the resistance to drugs kept on increasing. And today we have reached a stage where the primary drug resistance in India is something like 2.8%, with the acquired resistance with something like 16%. So I'll just finish it. So the causes of genesis of MDR are non-compliance to the antitubercular drugs. That is the most important. It is also because of the faulty prescription, faulty dosages, malabsorption, and other thing is that once a person has acquired resistance, what it transmits to other patient is what is called as primary resistance. So I'll stop here. We'll take the discussion forward.
Dr. Narendran, your focus too has been on MDR tuberculosis, and you have also focused on the oral medications for tuberculosis management. Could you elaborate on that?
Yeah, going by what the professor has rightly said, so there are 2 biggest problems encountered with respect to MDR TB. One is the non-compliance. But why should the patient be non-compliant? Is because of the duration in which is mandated by the disease itself. See, those were the days in which I was an undergraduate. When we had 24 months or 30 months of treatment with drugs being shifted, shuffled, being taken in and out, and this kind of shuttling has really caused problems with patients' compliance. The patient loses faith in the drugs, and then suddenly he stops, and what is called the cryptic non-adherence. He'll keep saying that, yes, I'm taking the drugs. On those days, we did not have this drug monitoring in the blood or in any other specimen. So this was one problem. The other problem was the physicians constantly shuffling the drugs. This is not a game where you can keep on shuffling your playmates. So it has to have a very long course of treatment followed by a strict adherence. which both of them do not get along with each other. See, if it's for a smaller disease, let's say you give treatment for 5 days, your adherence is quite good. I heard when I was reading one interesting documentary from the BBC, which said that among doctors in one of the primemost cities in one of the countries, among doctors, the adherence to a 5-day course of antibiotics was only 60%.
Right.
And imagine what will happen if you go to the masses and tell them to take drugs for 24 months. So our main interest was focused on this. There were lots of trials, and I'm glad and proud to say that we took it up. And when MRC approached us, and we are collaborating with the MRC London with this study called STREAM study, which is actually the evaluation of a shorter and standardized regimen of MDR-TB. Here, the basic advantages are two. One is we have shortened the treatment to 9 months, and it has been taken up by the WHO, and the program itself has got a shorter version. But of course, as our learned professor said, there are conditions in which you can use the shorter regimen. It is not generalizable at present. It is still in the research phase for everybody. Let's say, for example, a patient with HIV.
Yeah.
Let's say a patient with disseminated MDR-TB. In these conditions, you still require to give a longer duration of treatment.
Okay.
The second thing what we are arriving is trying to shorten it further to 6 months. And the other aspect is trying to do away with injections. As you know, that it's very difficult to give injections. All these people are very puny.
Yeah,
skinny.
MDR patients are quite many of them are back to injectable streptomycin, and there is absolutely no doubt that there is something known as patience and adherence and compliance. I came to know lately that Dr. Prasad, you have worked very closely with Dr. Khilnani. Am I correct? And
it's the other way around. I worked with him.
Oh, that's so nice. It's lovely to have two gentlemen. It's lovely to have two gentlemen on the panel who are not only collaborate, give credit, but mutually admire each other. But coming back to Dr. Prasad, what is the collaborative study that you did with Dr. Khilnani, or vice versa, whichever way you put it?
Okay. Just to give a little tracing to the research work that actually led finally to the collaborative project with Professor Khilnani, we were interested in understanding the basis of immune response and what was the difference in the quality of response between patients of tuberculosis and their household contacts. So we have these two groups of individuals that almost in the same sort of socioeconomic context, where you have these two groups of individuals, one a patient with frank tuberculosis and others who are not having any clinical signs and symptoms of tuberculosis. These two groups were the two groups that we always used and analyzed their responses. So one of the things that we observed that, and it had been reported also, was interferon gamma was a principal cytokine which was important for resistance and was the basis of resistance for killing intracellular bacteria, right?
Yep.
Now, so then using that premise, then we expect either low or no interferon being produced by patients, right? As compared to the resistant individuals. To our surprise, what we did find was that there was interferon being produced in patients, but the problem lied in its utility. So what we found was that the receptors for immune interferon gamma were downregulated in patients. Therefore, the biological activity of interferon gamma could not be expressed.
I see.
So we wanted to know what was the reason for downregulation of these receptors. And that was the collaborative project that I did with Professor Khilnani. And to cut a long story short, what we found was there was excessive production of alpha interferon in patients.
Right.
And alpha interferon is one of the principal cytokines which downregulates the receptor. And that is how we think that one of the reasons why we think patients remain a victim of the MTB, and they're not enabled to clear the bug from the system.
Dr. Prasad, you made a mention that you have worked on the development of biomarkers for identifying benefit response to therapy. And it's not just having a negative sputum test or a positive sputum test. And you did mention of cytokines and interferons in that as well, right?
Yeah, correct. the thing that we were looking at products of immune response. See that as you are now aware that antibodies are looked at, right? We look at T cell activity because MTB is an intracellular bacteria, right? And for expressing T cell activity, you need cytokines. So there is a whole plethora of cytokines which patients produce, right? Now, so we have to choose among that. So one of the things that we did was, in a part of that collaborative project, was to look at which particular cytokines that we can look at, right? And one of them that we came across again was alpha interferon. And alpha interferon we found in groups of TB patients, both pulmonary tuberculosis as well as extrapulmonary tuberculosis patients. We found a surge in the expression of alpha interferon in untreated patients.
Professor Khilnani, would you like to add something to this in your clinical practice? Because his aspect, of course, is research-based and you people have both worked together. So how do you fit in practice in clinical life?
So as I admitted, I was a junior partner providing clinical, all these things are very difficult to understand, but those have long-term implications. We looked at patients' resistance and, gave the data to Dr. Prasad and he published. So I think there's a little long way to go to have an implication of this study. But, but whatever we are today is because of the basic research.
Right.
So this research will see a light of the day, when it comes to the testing or the finding out which patient is likely to be MDR.
Yes.
But currently I don't think this has reached that. We have reached that stage.
It has not.
Dr. Narendran, you have worked so intensely and closely in so many trials. And you have worked specifically on trials where you wanted to use drugs which would be less toxic. You worked on shortening of the treatment span. You worked on oral therapy. Can you give us insights into your observations, practicalities of implementing it as a researcher and a pulmonologist both?
There are three dimensions to what we have done. So recently, many of the senior physicians would agree with me that most of the TB can be cured with shorter duration of regimens. Not that everybody requires a long, cumbersome span of treatment. The reason is that as the duration increases, your adherence rates comes down, your attrition rates go up. So if I have, so our dream was that if suppose we have a 3 months regimen or a 2 months regimen, then it will be a blessing in disguise, not only for the physician, but also for the patient as well. You can tell the patient that, yes, after 2 months, you don't have to come and visit my clinic. You can go to your office, you can go to your schools or colleges and do it. So that's a target. Of course, we have not reached that level, which I will admit very frankly. But what we are now trying to do is stratify the disease. This is a new concept, which is a priority in the global community. We divide the disease into minimal and advanced disease based on various parameters. It's not
kind of triaging, like we do triaging.
Exactly. Yeah. Where we have comorbidities and the presentation of TB as such on one hand.
Right.
Mycobacterial burden, which is evidenced by your smear grades and culture grades on the other hand. The third leg of the thing is the radiological extent of disease and the way it presents. So this is a gamble we are taking. Of course, it's a new trial which is coming up very soon. Here, what we are planning to do is to give a shorter regimen, a lesser toxic regimen for the less advanced or a minimal disease, and give a slightly longer duration of regimen with more potent drugs for the advanced disease. The basic idea is to optimize both, where on one hand we are trying to reduce the toxicity for the patients experiencing a minimal disease. On the other hand, trying to maintain the potency and efficacy for the advanced disease. So this is one new concept, which is very, very soon which will pick up. But this is in the research mode. It is not yet come to the trial. It's in the trial mode. It's not come to the...
I appreciate your words. You said it's a gamble, but you see, it's all about striving to get past all the hurdles. Dr. Khilnani, what are your clinical inputs into this?
No, the thing is that maybe I have not understood the question, but traditionally when we started treating MDR tuberculosis, and this is a national GIS study which came in early 90s, which actually had 52% of success. But I want to bring out certain facts, which are practical. As I said, on average, 9% of our patients have MDR tuberculosis. Now, talking candidly, very occasionally or not too often, we have the microbiological evidence of MDR TB. We have a gene expert which has its own sensitivity and specificity in the experimental setting. When it comes in the community, we keep wondering whether it is, how much it helps us. The culture sensitivity facilities with the LJ media takes about 6 weeks. With the bactec culture, it takes about 3 weeks, 3 to 4 weeks. And those facilities are also very limited. In the extrapulmonary tuberculosis, that is lymph node, port spine, brain tuberculosis, we almost never have microbiological evidence of MDR tuberculosis. Now, how do I treat? Since you have put this question to me,
yes,
we quite often treat these patients based on our clinical judgment. That doesn't come from a Jyotish Vidya. That comes from the fact that if the person has not responded to 6 months regimen of the conventional regimen, what we call as category 1 treatment consisting of rifampicin, INH, ethambutol and pyrazinamide. If the person is not responding in 3 months' time, we start thinking about this being MDR tuberculosis. Now, what a tuberculosis specialist working in the very advanced center talk about MDR is a microbiologically proven MDR. Where I worked at the All India Institute of Medical Sciences and where I work, I was quite often treating especially extrapulmonary tuberculosis based on the clinico-radiological judgment of MDR tuberculosis. And there comes little bit of difficulty. Now, the conventional treatment for MDR tuberculosis involves 6 months of injection, which is not streptomycin. It is kanamycin, capreomycin, and amikacin. Now, these drugs are very difficult to tolerate because they have their adverse effects. There is a definite risk of hearing impairment. There is a vertigo or giddiness which may become permanent. There are other drugs which have their very severe side effects. So, adherence becomes a very big problem with that. But having said that, in my experience, although the study mode say that 50% people get cured of it, but in my practice, I saw a success rate which was way higher. Other thing I want to say that some people, even in the extrapulmonary tuberculosis, require treatment for 24 months or even longer. I might have treated, any tuberculosis expert would challenge me that why did you treat this patient for 2.5 years? But I did that because patient had not been cured. So these are challenges that a clinician faces. I am not undermining the microbiology, but India has gone much ahead. We have very advanced. Yes, sir. You want to interrupt me?
Yes. Doctor, I don't want to interrupt you, sir. I just want to forward a question to Dr. Prasad, your close friend. Dr. Prasad, you did mention to me that, in Chingalpet, ICMR had done a trial, PCG vaccination being given at birth. Even an endemic area like this, that there was tuberculosis negative cases. And you really wondered, is it right vaccine to give? And that you have actually done research on, finding out why tuberculosis vaccine. Could you give insights into your work and thought process?
Okay. That's a very big trial which was conducted for which was monitored for more than 10 years in Chingalpet, where, in the placebo group of individuals, despite living in an endemic area, remained tuberculin negative. So this was perplexing. So we were trying to analyze what was the kind of immune response would be there in tuberculin negative individuals compared to tuberculin positive individuals. To cut a long story short, we were looking for components of the tubercle bacilli which would be picked up by either of these groups of individuals. So we came across one such particular protein, a DNA binding protein, which we described as a DNA binding protein expressed also on the surface of the bacterium, which we also showed by immunogold electron microscopy and other things. This particular protein and its gene that we analyzed, we realized we could use it to distinguish two closely related mycobacteria, namely MTB and Mycobacterium bovis. So using this, and we developed a PCR test, and we analyzed clinical samples, and we focused on extrapulmonary tuberculosis, because as Dr. Khilnani mentioned, it is a more difficult form of tuberculosis to demonstrate the bug. So we did that, and then we discovered that there could be MBBS, especially in tuberculous meningitis in children.
Mm-hmm.
And the same assay, we used it for examining bovine samples. This was in collaboration with the Central Military Veterinary Laboratory at Meerut. And we were able to show both MTB being present in bovine samples as well as MBBS. So this was a demonstration that MTB has other victims, and where other reservoirs where it could continue to be present, continue to be transmitted, right? Both from humans to animals, from animals to humans. And this has to be taken into consideration with regard to the developing good strategies for control of tuberculosis.
I see.
So just focusing only on human tuberculosis, we have to see this, great network of tuberculosis which exists.
So you have been deeply into investigating zoonotic tuberculosis and elucidating the immune response in human tuberculosis, which led you to work upon zoonotic tuberculosis.
Yes.
Would Dr. Gopalan like to give some inputs on that?
Yeah, as both the professors had said, it's really it's still a Pandora's box, because the place where you require the resistance pattern, especially in extrapulmonary tuberculosis, affecting very crucial parts, let's say the spine, let's say the meningitis, you don't get a good yield of bacteria, as rightly said by Professor Khilnani. That is the place where we are still in a gray zone, whether to extend the disease, extend the treatment, whether to increase the dosage. So we still are not in a classical position as in pulmonary tuberculosis, even though we still give importance to pulmonary tuberculosis because that gets transmitted. You don't get the spinal tuberculosis gets transmitted and all that. Now we are also seeing disseminated TB not just in immunocompromised hosts like HIV. We are seeing a lot of other immunological diseases also having this kind of a disseminated thing. And the culprit goes into what Dr. Krishna Prasad sir has said previously. There are a lot of people who are having interferon gamma deficiency, having lots of other T cell group deficiencies where TB can extend inside and causes tissue damage where there is no evidence obviously seen unless you do a biopsy of that place, where you require tertiary hospitals or specialized care where we can find out. Just to find out that it is TB, let's not talk about the resistance pattern. That's even more complicated in these cases. Again, the question of, even though we have formidable diagnostic tests like the nucleic acid amplification assays, you have CBNAT, you have TrueNAT, which has been an ICMR product thanks to DG, which recently WHO has taken up, a simple mechanism at a cheaper cost. The reason we say is most of these extrapulmonary tuberculosis have got a resistance pattern, even though they may not be resistant at all. So there are lots of discordance between the clinical presentation and the microbiological resistance pattern. So that puts you into a very great difficulty for the treating clinician, especially in extrapulmonary tuberculosis. Pulmonary tuberculosis is much more easier to handle, I should say, compared to extrapulmonary tuberculosis.
Dr. Gopalan, you've just mentioned of the newer diagnostic techniques of PAC. So how would you quantify, adjudge the sensitivity, specificity, cost factor, practicality of the newer technique vis-a-vis the age-old standards? And if there were to be the simplest test to do, which would it be? If it would be your last call to get a positive or negative as a diagnostic modality, which would be the test? But of course, there is biopsy.
Even though I'm a researcher, I will first proudly call myself a clinician. So all the laboratory tests, whatever we do, as you are aware, has to supplement or complement your diagnosis. You cannot straight away go by the test, whatever it may be. There is nothing called a precise test with a sensitivity of 100% and a specificity of 100%.
Right.
But techniques have helped us to take decisions faster at an earlier place, so that we can deal with patients in much more efficient way. For example, the Lowenstein-Jensen, the classical culture medium, which is still the gold standard, it will take 6 to 8 weeks for the cultures to grow. So by
Honestly,
the time
people have no patience, They hardly have patience, and practically so many of the clinicians hardly send it for an LJ, and they say it takes 6 to 8 weeks, forget it. At least we start. I understand there is an imperative need to start off therapy early, but at least the patience for that, and then thereafter figuring out if there is a drug resistance to it, the impatience is really high at so many points.
sorry to interrupt. I think I misinterpreted. Nobody waits for the cultures to give you the answers. You start treatment and side by side you wait for the cultures. But now, apart from that, now you have these gene expert available. Gene expert is now becoming much more easy even for newer drugs. Now we have the gene expert being fine-tuned and true not fine-tuned to bedaquiline, to fluoroquinolone. So we have come a long way with respect to this NAT testing, that is nucleic acid amplification testing, just not for rifampicin alone, for the other drugs. So you get the results in 2 to 3 hours. The problem arises when there is a discrepancy between your conventional culture and these faster tests. Which one to rely upon? There you have to use your clinical acumen. As rightly said by the professors, if you see a clinical improvement in the patient, even though you may have a resistance pattern, you then introspect. Take it with a pinch of salt. But if your thing goes on, like what I am saying, that the patient is not responding at all despite your treatment, check his adherence first. And then there's a stepwise manner in which you need to attend to these patients who do not respond to TB therapy.
As they say, simplest things first. The simplest elimination factor needs to be compliance, adherence, and then comes further on. We did make a mention very significantly about the side effects, which amongst which hepatotoxic side effects are quite prominent. And we have Dr. Khilnani here, who has had an special interest in the study of the hepatotoxic side effects of ATT. Sir.
So hepatotoxicity, the 3 drugs from the category 1 drug, one regimen, that is rifampicin, INH and pyrazinamide are hepatotoxic, and 2 to 10% of the Indian patients would develop hepatotoxicity. And actually I was a young research officer in a project which was done by Dr. J.N. Pandey, funded by Medical Research Council UK, and I have worked actually first hand, not as a boss. So I have had actually one who works get the perfect feel of what happens. So when the patients take antitubercular drugs in the first 3 weeks, they get gastric symptoms, they get loss of appetite, sometimes they have vomiting. We have all felt that. And this liver function derangement is seen in 30 to 40% of patients. So the SGOTPT, as we call it, they rise. And patients have vomiting, loss of appetite, the distaste for food. Now, this is not an innocuous adverse effect. It can kill the patient. There are mortalities also. As I said at the outset, it also hampers the continuation of therapy, leading to the risk of multi-drug resistant tuberculosis. Now, there are people, when I started this project, working in this project, the risk of hepatitis in Indian patients was, as reported, sometime to the tune of 30%. The reasons for that was that pyrazinamide was given in the dose of 50 milligram per kilogram body weight, which was subsequently reduced. Other thing was that Indian patients have low body weight. As we know, traditionally tuberculosis patients used to be 30 kilos, 25 kilos, and they were given a tablet of 450 milligram of rifampicin. The dosages were not given according to the body weight. Right. Other thing, what we found out, that people who were malnourished, who had low BMI, those who were taking alcohol in the past, those who had positive for hepatotropic viruses, those had low albumin, and those had severe disease were at the high risk of developing hepatitis. We also found out that pyrazinamide was not more hepatotoxic. Cutting it short, all these patients, although the guidelines do not say that these patients should be monitored with liver function test, but I do propose and insist that these patients should be monitored with, if possible, with the liver function test.
Get the LFT done, OTPT at least done every 3 months, if not 6 weeks.
No. The drill that I follow is that for first 2 months I get it done every 15 days.
2 weeks.
Other thing and the adverse effect we find is hyperuricemia leading to severe joint pains, and it is extremely common. and it is because of the pyrazinamide. So what I want to say that relating to our primary discussion of MDR, now in a programmatic setting where there is no LFTs, people are given anti-tubercular in the villages, you don't follow them, you just give them drug for 1 month and ask them to come. If a person has developed hepatitis and he has distaste for food, even the sight of food, the thought of food makes him nausea, will he take anti-tubercular? No, he won't take. That is one of the reasons for non-compliance to drugs leading to the development of multi-drug resistance.
Over to Dr. Prasad. Dr. Prasad, why is it that patients are unable to control the spread of tuberculosis within their own selves despite the medication? And how do we really decipher the impact of the tubercle bacilli infection on the human response system?
The MTB has several mechanisms by which escape mechanisms by which it can overcome the immune response. Okay, like I described one very much in the start of this program, where I said, despite the ability of patients of tuberculosis to produce interferon gamma, which has been shown in experimental systems in mice, etc., where interferon gamma is the principal cytokine, they are not able to utilize it. There is no biological activity, there's no biological impact of it. And one of the reasons is, as I expressed, was that the downregulation of the appropriate receptors. Besides that, MTB has several mechanisms have been described, where downregulation of immunocompetent molecules on the surface of cells, therefore there is lack of recognition. The escape of tubercle bacilli from the phagosome into the cytoplasm, again to escape the microbicidal mechanism, just a few of these that I'm telling you about. Then its ability to mask itself, to prevent recognition or to stimulate an appropriate immune response. So these are the things that contribute to, the persistence of bacteria. Further, the other thing is the efficiency of the chemotherapeutic agents. As Dr. Khilnani mentioned, absorption, distribution, whether it reaches in adequate quantities to the different tissues, to the different depots where the bug is present, where is it enough in lethal concentrations to kill the drug. So all this matters. And resistant drugs are able to develop mechanisms by which they can pump out these drugs, from the system itself. And that's one of the mechanisms where they can establish inherent resistance to the regular antitherapeutic drugs that are used. So there are these multitude of mechanisms which have been described, and where it leads to big
Dr. Narendran also has a lot of interest in studying the immunology. And we know there are patients who were positive and then post-ATT they became negative. But then they may be challenged by the immune reconstitution syndrome or the paradoxical syndrome, wherein now you are ATT negative, post-ATT you are negative, but your clinical status is deteriorating or the radiological findings are worsening. So there may be a hyperimmune reaction, there may be TB iris. So Dr. Narendran, what would you like to explain to the audience here?
Yeah, it's a very, very interesting syndrome which we initially used to find it very commonly. Yeah, that is tuberculomas and lymph nodes enlarging in size during treatment. Mm-hmm. So as professors have rightfully said, in extrapermanent tuberculosis, it's very difficult for us to find out or differentiate them from failure versus this paradoxical reaction. But in HIV, under Dr. Soumya Swaminathan, I could really see that it's a very, very common manifestation. We have in fact published 15 to 20 papers on iris. Right. It's a very, very, I would call it as a predestined fury of the perturbed immunity. Somebody has tied up your arms and legs, and somebody is trying to criticize or trying to play the fool with you. You remain quiet, but you are definitely agitated. But when the noose is cut off, when the thread is cut off, you go and give a slap to them. In the same way, the immunity is actually there, but it is ineffective. But when ART is given, that is antiretroviral therapy is given in HIV patients. It is not very specific to HIV as such. It can occur with any immunocompromised status where the person becomes immunocompetent based on therapy, or let us say a transplant patient on various immunosuppressants, and the immunosuppressants are taken off suddenly. So in any of these cases, you will see that. In fact, COVID also, you will see that the cause of death in COVID, one of the mechanisms is due to this kind of immune reaction. It's called a COVID.
We'll get back to HIV and COVID, but I'd like to ask Dr. Prasad, have you dwelled into this area of research, and did you come up with some pertinent findings?
No, I haven't done comorbidities at all. I've always ruled out HIV as one of the HIV positive individuals I had never included in my study, because that would complicate.
I was asking you regarding the paradoxical syndrome.
No, I have no experience with that.
I see.
In fact, Dr. Khilnani would be the person for that.
Yeah, back to Dr. Narendran.
If I could add to it, it's true that with HIV, the iris or the paradoxical reaction is very common. But as a clinician, I can tell you, especially with the lymph node tuberculosis, another kind of tuberculosis, patient comes to you, you diagnose on a solid ground that he has tuberculosis, you start him on treatment, he starts developing fever, he starts feeling unwell, and his lymph node size increases, sometimes it bursts. Then the patient tells you, what the hell you are doing to me? You are giving me treatment and I am having, symptoms are increasing. But this actually does not mean failure of treatment.
Right.
It is actually what is called as hyperimmune syndrome or iris or whatever you call it. The treatment is that you should recognize it, rule out drug-resistant tuberculosis, and sometimes we have to give steroids to suppress that immunity and continue with the anti-tubercular treatment. That's the clinical part of it. Thank you.
Right. Yeah. Dr. Narendran, we are very well aware that first came tuberculosis, then came HIV, and HIV with its immunocompromised status brought in more infections of tuberculosis and other opportunistic infections also. So how do you rate the burden of this? Also, how do you look at other situations where the patient may not be having HIV, but there may be comorbidities? So do comorbidities bring in higher chances of developing tuberculosis, and vice versa? Does tuberculosis per se bring in more comorbidities? We know, we have talked about hepatotoxicity, other toxicities, hyperuricemia, etc. But can you please elaborate? And it's a two-pronged question. It's HIV and tuberculosis, and it's also about comorbidities and tuberculosis, vice versa.
So you are asking me to talk about Ramayana in just 5 minutes. So that's a very difficult thing to make. Maybe Lord Hanuman, anything for that matter.
Yeah, I am as helpless as can be. I have asked you so many questions, but then when we invite stalwarts, we expect them. So they say, you give that that particular herb, which is that final gutti, which is the take-home message. So, in your words.
So taking Lord Hanuman into my my prayers, I will try to make it very short. See, TB, what happens? It increases all your cytokines, which actually proactivates HIV replication. So most of the times we know what HIV does to TB. Nobody knows what TB does to HIV. So we have seen that there's hyperactivation, and that is one of the reasons for your immune reconstitution, which we are discussing previously. But considering what HIV does to TB, HIV starts masking the avatars of TB, starting from diagnosis and complicating it up till treatment. So diagnosis may be very, very bizarre. Patients may have just fever. Secondly, there may be non-tuberculous mycobacteria, which are totally not considered with TB at all, because there's a different way of approaching these diseases. There's a whole lot of spectrum of mycobacteriosis which can occur with HIV, which may mimic TB very closely, starting from nocardiosis and other NTMs, as we call it. Secondly, when it comes to presentation, even in pulmonary tuberculosis, you have lots of atypical presentation. To put it in a very small thing, as of now, we have the policy of test and treat. So you don't have many complications as we saw initially. PCP, nocardiosis, these are some of the opportunistic infections which can exactly mimic TB. But there are clues for us to find out as clinicians. If your CD4 was quite low, you usually have atypical mycobacteria causing atypical presentations. If your CD4 was somewhere between 200 to 400, you'll have typical mycobacteria, that is Mycobacterium tuberculosis, causing atypical manifestation. If your CD4 is quite high, let's say above 400 or so, you have typical mycobacteria having typical manifestations. The other problem arises with the drug-drug interactions with all these comorbidities, any disease for that matter. If you take ART, there are only certain antiretroviral therapy which can be conducively given with antimycobacterial drugs. For example, now the spectrum is also changing. There are a lot of antiretroviral drugs which are now first-line drugs which are given in the Western world, which is not compatible with antituberculous treatment, especially when we are giving it rifampicin. Again, there are lots of drugs which have QTC prolongation on both sides which you cannot give, like protease inhibitors along with the newer drugs like bedaquiline or telamine. So these are the complications created by HIV. The other biggest problem is malabsorption, as most of the professors already mentioned it. That is where it is something called cryptic non-adherence, where I'm very proud to say that our institute is one of the fewer institutes in India where we do what is called therapeutic drug monitoring. You take the drug, the patient is very regular with his treatment, but nothing gets absorbed because of the problems caused by HIV in the gastrointestinal tract.
Right.
So what happens? There is a lesser concentration of drugs inside the body, even though he consumes the right amount of the drugs. This can lead to very disastrous effects, including drug resistance. So one of the commonest problems is increased drug resistance in HIV. And one of the most important and prominent causative thing is the malabsorption which is caused. This is with respect to HIV. One sentence regarding diabetes and tuberculosis. Now we see a lot of patients with TB having what we call as thysic diabetes. That is like gestational diabetes. When they develop, they were not known cases of diabetes mellitus, but when they are started on TB treatment, we find out that they are recently diagnosed diabetes because of a lot of things. Because TB causes increased endothelins, causes stress, and there is endogenous steroids and lots of factors which can cause. And we are able to see the presentation of TB is a little unique in diabetes, where you have multiple cavities. That is something which we do not get it in ordinary TB without diabetes. This is one thing. Secondly, we are getting a lot of drug resistance among diabetics as well. And it will be puzzling to know that the concentration of drugs like pyrazinamide is much more in diabetes, whereas the concentration of drugs like rifampicin is less in diabetes. That means that's the differential absorption of drugs in diabetes. We do not know the exact answer, because when we do these studies on pharmacokinetics, it's a very small group which we are looking into. Still, we need to know the clinical implication of these findings. Now, let's find out what TB does to diabetes. Most of the times we see that these TB patients develop more of hypoglycemic spells or lots of dysglycemias, not only due to the drugs like quinolones, but also due to the disease per se.
Right.
And the senior physicians will agree with me that it's better for us to give insulin rather than oral hypoglycemic drugs, especially the cheaper ones.
Right.
People can afford to take gliptins and glyphosins, it's a different issue altogether. But still, if you are looking at Dianyl, that glibenclamide, and except glimepiride, the other sulfonylureas are not much safer to be given in TB patients, because we are seeing lots of hypoglycemic spells where we need to be really careful. As you know, hyperglycemia, you can always tame it. It takes a long time for you to attack, whereas hypoglycemia is like a tiger. Immediately it attacks and kills someone. So these are the problems which can occur with these comorbidities.
Thank you for your lucid response. I will request Dr. Khilnani for any quick inputs that he would like to make on this. We are now short on time.
I'll be very brief on that. So, as a internist or physician, which I was majority of my career, I see tuberculosis not only in diabetes, but patients who have undergone malignancy, patients who have got connective tissue diseases, patients who are on steroids, patients who are on other immunosuppressant drugs. These people are more likely to have tuberculosis, and one group that I would like to mention is pneumoconiosis, that is silicosis. Patients with silicosis have a very high incidence. Almost all of them have tuberculosis because their alveolar macrophage function gets disrupted. Now, these patients not only have more chances of having tuberculosis, at times their response to antitubercular drugs is tardy, irrespective of their sensitivity pattern, because of the altered immunity. So that has to be kept in mind, that these patients are required to be given antitubercular drugs for longer than the usual time. If the usual time is 6 months, we give them longer therapy. And that also I practice in I'll just finish in 10 seconds. That also I practice in bone tuberculosis and brain tuberculosis and also other extrapulmonary tuberculosis. Then I never restrict myself to 6 months regimen. I give them longer regimen. Thank you.
Welcome, sir. Dr. Prasad, you also have a keen interest in working up extrapulmonary tuberculosis. What is your practical inputs in it?
Oh, I had only worked on in trying to develop PCR techniques to demonstrate the presence of MTB or Mycobacterium bovis in clinical samples. And in that regard, we had looked at a range of extrapulmonary tuberculosis samples, starting from lymph nodes to endometrial biopsies, CSF, pleural fluid, so on and so forth. And we had seen the distribution of these two bugs, namely MTB and M. bovis in that. That was the only contribution we were trying to make in terms of doing a diagnosis and to pick up the bug trying to have a more efficient diagnostic test for each.
Dr. Gopalan, who do you think and what do you think are the new kids on the block when it comes to newer drugs? And what would you rely upon? And what would you look forward to as a drug being developed?
There are lots of new drugs in the pipeline, but the problem is that it takes a long time, as you'd have seen in COVID. So it's a real challenge that out of 400 drugs or 400 promising products, maybe one or two. It was nearly 60 years after the older drugs that Bedaquiline came into the market, then there was a flourish of newer drugs. But now these drugs, ideally speaking, should be aimed at shortening treatment. Most importantly, lessening toxicity. It should be like an ice cream being given to a child. A child will be quite willing to offer its hands to you when you.
I totally enjoy the similes you use, sir.
But we are still far ahead. So it's almost that is the journey which we need to go into, where like if you give ATT, people should be happy to take it. So this is not the scenario now, where a lot of perseverance as well as pertinent counseling needs to go into the patient's brains before they adhere to treatment. And it is not very easy because, just as I told you, just taking antibiotics for 5 days, we feel upset with lots of things.
Dr. Khilnani, what is your experience and which drug are you hinging towards?
Oh, the thing is that I practice critical care medicine. So, we use colistin, which was an age-old drug, which we are using now. Similarly, in tuberculosis, we are using clofazimine, which is an age-old drug. We are using para-aminosalicylic acid. That's the age-old drug. As Dr. Narendra has said, the new drugs are not coming. Bedaquiline and delanamide has come, and they seem to be, a game changer. But it has to be seen whether in community they will come. So, I sort of seen in 30 years of my practice treating MDR tuberculosis that I didn't get any new drugs all these years. I was using same capreomycin, kanamycin, and
so HIV and COVID.
Sorry?
HIV, COVID, and tuberculosis. So let's just figure out the correlation that we may be fearing in terms of a tuberculosis patient affected with COVID or a COVID patient getting, being at a higher risk of being impacted by tuberculosis. Any correlations, any takeaway for the audience?
So the thing is, I can tell you because I have been managing a lot of COVID patients and tuberculosis, of course.
Critical care,
so far, so far, see, the thing is that COVID is a self-limiting disease. It kills, but those who survive would get rid of it. The usual time is 10 days, but we have seen it sometime going on for 50 days, 60 days. So I haven't found a direct correlation of COVID with tuberculosis. I have found with COPD and other diseases, but COVID and tuberculosis direct relation is not there.
My last question to you all, and I'll ask you to give me brief answers, and it will be from the aspect of all three of you. So, Dr. Narendran, what do you think the government is doing to get rid of tuberculosis, or at least to tide over the multi-drug resistance, or in terms of any program, any headway as a way forward?
Yeah, actually, if you see, the program has caught up nicely with the research, not only in India, but even globally. So when I spearheaded the RCT of daily versus intermittent ATT, before we could get the results, the program changed to a daily regimen based on our findings and communication to the ministry as well as the global research. So it is not just that the government is only looking at what is happening in India. So it is happening everywhere. That's the same scenario where we have the BDCAP program where the bedaquiline was given under access to the program. There are lots of costly drugs which are being given free of cost for the benefit of the common public. And I'm very glad to say that Dr. Padma Priya, who is the current director of our institute, she along with Dr. Soumya Swaminathan spearheaded the movement to bring bedaquiline into India. We treated what you call as patients with hopeless resistance pattern, almost 33 of them, even before bedaquiline was available in India, by getting into an affidavit with the courts and other things, and lots of complicated procedures were there, and with the DCGI trying to get these drugs. So government is trying its best to do this, and you know our Prime Minister's dream of trying to eliminate TB by 2025. It's a real Herculean task, and hats off to all these people, even during the time of COVID. Of course, we do agree that all other diseases got a setback because of true, it is quite understandable because of the lockdowns, other things, but there were instructions given to give these drugs to the patients, trying to make them take it, and trying to give them cough etiquette, trying to minimize the there are lots of provisions financially also being provided to the patients for taking the
unpredictable stress of COVID caused a lot of stress to the patients who are actually suffering from other diseases as well, be it people on dialysis, be it people who were ongoing treatment for tuberculosis and the likes of the same. Dr. Prasad, what do you think the government is doing?
Well, I think the most important thing would be, besides looking for newer drugs, is to develop efficient vaccines for tuberculosis, right? We've been depending on BCG. BCG has its potential beneficial effects, especially in children, right? And prevention of extrapulmonary tuberculosis. So I think the push must be for developing newer vaccines and to permit trials with candidate vaccines, which could help us in eliminating tuberculosis, not only for humans, but also for animals.
Dr. Gopalan, if you want to add a point, I'll get back to you in a minute. Yes, sir?
Yeah,
yes,
NIT is contemplating on a huge vaccine trial with two of the newer candidates, as what Sir has said. Instead of just relying on BCG, it's around 15,000 candidates. We are trying to look at the contacts, whether there is a breakdown of TB among contacts of patients with tuberculosis. So this is
Dr. Prasad, did you finish your point, or
yes,
anything
ma'am, I'm finished.
Dr. Khilnani, over to you, sir.
So I feel quite dwarfed with this stalwarts besides me, because of the thing that, I'm a critical care physician and whatnot, and I do treat tuberculosis. But having said that, I'm following the tuberculosis and treating a lot of patients with tuberculosis. India has done a great job, and TRC Madras, as it was known, Tuberculosis Research Center in Madras, has a credit of bringing in short course treatment in India. They have done amazing research in the field of tuberculosis. And I just want to say that this is because of the people like Prasad who do a basic research, people like Narendran who actually do all kinds of research. But we clinicians use it. We are the end users. So I really don't have to add, but give my credit to both of them for working in the field. Thank you very much.
Sorry.
Final comment. Even to do quality research, you need quality clinicians. And to really give us characterized patients, and so then only we can come out with answers. And that is where Professor Khilnani has really contributed and helped us in our research programs.
So to say, it is so nice to have a panel of three people from their own distinct forte of practice, research, and an amalgamation of all the three coming together on this platform. But yet again, what has really humbled me and what has made me feel so happy is the fact that all three of you appreciate working in tandem as in representatives of each of your field, and working together to get rid of tuberculosis. And you all value and appreciate the fact that it takes not one, but two, but many to tango, maybe. With this, I'll come to the close for the session. World Tuberculosis Day that we are today hosting this program for in order to create awareness. The platform today was to bring forth the various aspects and challenges which you and I in our routine clinical practice may not envisage upon, may not dwell upon, as in what is happening behind the curtain as well as in front of the curtain in terms of various aspects. As you people have mentioned, it's a journey which is still a little long, with hurdles, with stumbles, but with resilience, patience, and compliance from the patients. With this, I end the show. This is me, Dr. Puja Dewan, your show host and moderator. And I am truly delighted to connect with you all and wish that this platform today was enlightening enough for the audience who watched us. Thank you so much.
Thank you so much for giving the opportunity to listen to two of the clients. So it was the wisdom which I could hear and educate myself. Thank you, ma'am, and thank you, sirs.
You're most welcome, all of you.
Dr. Gopalan. Thank you, sir. Thank you very much.